Hi, my name is Gustavo López Cruz. My topics are immunotherapy in renal cell carcinoma and Ribavirin for chronic hepatitis E virus infection in transplant recipients. Topic 1, definition. Renal cell carcinoma, RCC, is a type of cancer. It's the most common and occurs more frequently in men. This begins in the lining of the renal tubulus. The most common treatment is the total or partial removal of the affected kidney. However, immunotherapy is being studied as a treatment. Topic 2, definition. Hepatitis E virus, HIV, genotype 3 cause self-limiting infection in non-immunocompromised patients. However, it can link to chronic hepatitis and cirrhosis in patients who have received solid organ transplants, patients with human immunodeficiency virus infection, and patients with hematologic cancers who have received chemotherapy.
I will present a study called RADVAX, so radiation vaccination, if you will. It's a small study that asks the question, do we see something about this mysterious romantic abscopal effect in kidney cancer? So the question is, if we apply definitive radiation, high dose stereotactic radiation to a tumor site, can we potentially increase the response rate to potent immunotherapy? At the time when we designed the study, we took the most potent immunotherapy that there was, nivolumab/ipilimumab, a PD-1 and CTLA-4 inhibitor, and then really applied 5 fractions of high dose, very precise radiation to 1 to 2 tumor sites. And the question is, do we potentially see an increased response rate as a signal that maybe that approach may improve the benefit from immunotherapy? It's a small study, was supported by BMS with free drug, and more importantly was supported by philanthropy from patients actually to be able to pull that study off. 25 patients, we did see an increase in response rate, so we do see a signal that this approach may actually increase and benefit the immune response in that context. It will be opposed to data from an Italian study that used a little bit less radiation in just PD-1 monotherapy, where they did not see an increase in response rate. So maybe this particular combination, maybe the presence of the CTLA-4 inhibitor, maybe the intensity of the radiation, maybe some of these factors are important to do it. It's a small study and it's all the caveats of a small single institution study. And there needs to be some complementary data generated to confirm the findings. One of the ways we're moving this forward with is that we are going to do PD-L1 PET imaging of patients. It's a very novel way to light up all the tumors in the patients and then see how inflamed are those. And then potentially pick out the ones that are the coldest, less inflamed tumors, aim the radiation to those particular disease sites, and see if that in particular will boost the immune response to otherwise very difficult to treat kidney cancer tumors. At this point, I would call it as an encouraging activity signal. It's by no means definitive, but I think that it's worth pursuing and seeing if this approach can enhance immunotherapy and potentially, broaden the benefit from immunotherapy to patients. I think there is a number of those. I think this is a very unique one where we took this particular combination. Again, PD-1 monotherapy also presented just before our presentation in the oral session was a negative trial. And so it will be very interesting to look at differences in the trial design and the outcome. But again, what we suffer from is that we have 25 patients, so it needs to be confirmed. But I would say for 25 patients, it's an encouraging activity profile. And we will have to demonstrate that this holds up across a larger patient cohort.
Applications in medicine. Topic 1. Immunotherapy is a type of cancer treatment that boosts the body's natural defense to fight cancers. It uses substances made by the body or in a laboratory to improve, target, or restore immune system functions. Certain types of immunotherapy attack cancer or slow it spread to other parts of the body. Others make it easier for the immune system to destroy cancer cells. Topic 2. Today, there is no established therapy for HIV infection. A reduction in immunosuppressive therapy, mainly immunosuppressants, can target T cells has resulted in HIV clearance in nearly 30% of solidarium transplants recipients with chronic hepatitis. Small case series and case reports in the population have shown that a short course of pegylate interferon or ribavirin has monotherapy can effective treatment HIV infection.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent-to-treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Pros and cons. Topic 1. Pros. Immunotherapy can be alternative treatment to the removal of the kidneys, which will improve the patient's life. Nivolumab, in combination with ipilimumab, have shown efficacy in the treatment of renal cell carcinoma, RCC. Cons. Limited efficacy with significant toxicity. Immunotherapy sometimes causes the immune system to attack healthy cells, which can cause side effects such as fatigue, skin reactions, nausea, vomiting, muscle pain, headache, among others. Topic 2. Pros. At the end of therapy, HIV clearance was observed in 95% of the patients. A sustained Viral leak is response defense has undetectable serum HIV R&E level at least 6 months after cessation of Ribavirin therapy, occurred in 46 of the 59 patients. Cons: a recurrence of HIV replication occurred in 10 patients after Ribavirin was stopped.
Hey, thank you for watching Medicosis Perfectionalis. Hepatitis E mnemonic. The E mnemonic, also known as the EU mnemonic, coming up. Hepatitis E. Remember, EU. It causes jaundice in the Far East, Egypt, and by Egypt I mean Africa. And by the way, Egypt is my home country. India, Central America, contaminated water, ew, contaminated is ew, undercooked seafood. Sometimes some genotypes of Hep E are endemic in the swine. So undercooked pork can cause Hep E hepatitis. So swine, pigs eat everything, including garbage and worms, so that's ew. No offense to pigs. Fecal-oral route of transmission. Sometimes it's common in pregnancy, and when it comes to pregnant women, it's fulminant. Fulminant means massive necrosis, which can lead to failure. Ew. And there is marked cholestasis in hepatitis E. Mostly it's acute. In these countries, sometimes it's the most common cause of acute viral hepatitis. Wow. But, however, it also can be chronic, such as patient with HIV or patient with immunosuppression. Some textbooks, including Harrison's, which is my favorite book, I will link it in the description, it regards Hep E as an opportunistic infection for people with HIV. So, acute will have IgM antibodies in the blood, and chronic will have anti-HEV IgG. It's very similar to Hep A on electron microscopy. To remember that A and E are both vowels. Okay? Remember Hep D was dependent on whom? On Hep B. So you can draw D like this, and you have B, and A and E are vowels, so they go together, and these go together. Anyways, so that's it. Now you know everything you need to know about hepatitis E. But wait, there is more. And now, question of the day. Which type of hepatitis is the most commonly associated with sexual exposure? Is it Hep A, Hep B, or Hep C? By the way, if you go to my Facebook page, there's an album there, contains all of the questions. This is the 4th question, so if you need to get them all, go to my Facebook page. Now, all you need to know about Hep E. Please go ahead and enjoy the rest of the day, and I'll see you later. Thank you very much.
Issue update in Ecuador. Topic 1. In Ecuador, there are no specific statistics of renal cell carcinoma, but according to Solca, in 2015 in Guayaquil, 94 men and 63 women were diagnosed with cancer in the urinary tract. Topic 2. In Ecuador, hepatitis E is very rare. In 2020, there have been 68 cases of hepatitis B. There are no statistics of hepatitis E. This is more common in Asia.
hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis for which other causes have been ruled out may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
Conclusion. Topic 1. Immunotherapy has changed the landscape of management of metastatic RCC. The combination of drugs such as lenvatinib and everolimus, nivolumab, and cabozantinib, or lenvatinib and everolimus, have shown efficacy against renal cell carcinoma, RCC. Topic 2. Conclusion. In conclusion, a multicenter study showed that Ribavirin as a monotherapy may be effective in the treatment of chronic HEV infection. A 3-month course seemed to be an appropriate duration of therapy for most patients.
You've looked at the hypothesis that statins might be of influence or of interest in renal cell carcinoma. Could you tell me about the analysis that you've recently done?
Certainly. So we conducted a retrospective review of a pooled clinical trials database exploring the benefit of statins in patients with RCC. There's been preclinical studies to suggest the anti-proliferative effects of statins, and in other cancers such as prostate, breast, colorectal cancer, statins have been shown to actually improve cancer-specific survival.
Now, you said you did a pooled analysis, but what sort of patients were you looking at, and how did you get to the statin data?
So the patients that we were looking at were patients who were enrolled on clinical phase 2 and phase 3 clinical trials. We had about over 4,500 patients in the study, and patients were either receiving first-line or second-line standard therapy for kidney cancer. And so that was our patient population.
And how much did the statin use vary between different members of that group?
So 10% of the patients in the group, about 511 patients, actually were statin users.
So you had a sample of 400 or so patients who were statin users. Did they stand out from the rest?
They did. And so the statin, in regards to their survival, patients who were statin users had improved survival compared to patients who were not statin users.
By how much?
By 6 months, which was statistically significant.
Yes. So what do you think doctors should read into these data?
So this is a retrospective review that's very hypothesis generating as to do or don't, or as to whether statins actually influence outcomes in RCC. I think there's a couple steps in moving forward. One is trying to understand mechanistically why this is. So trying to analyze this in the preclinical setting. And the second step is looking at the benefit of statins in a prospective fashion in a clinical trial, basically.
What do you think the mechanisms might be?
So it's hard to postulate. So there's in vivo data suggests that actually statins can inhibit proliferation, they can induce apoptosis, they can affect DNA damage, and so it's postulated that through these mechanisms and possibly some synergy with the VEGF targeted therapy and mTOR targeted therapy, they could be employing their benefit.
And do you think that benefit might be confined to renal cell carcinoma, or could it be more widely applied in oncology?
So possibly more widely applied. I think the reason we're looking at in renal cell carcinoma is because of the fact that it has previously been shown to be potentially impacting survival for patients with colorectal cancer, breast cancer, prostate cancer, some of the major cancers that are out there. So, you know, it's never really been looked at in RCC. So we looked at it in RCC because of, you know, the data that's already been out in the field.
So what's the brief take-home message then coming out of your study?
So the brief take-home message is for patients who have an indication to be a statin user, such as dyslipidemia or cardiovascular disease, use of statins in patients with metastatic RCC may actually impact their survival.
Thanks.